Welcome back to Pulamet. Today's topic of interest is heat stroke. We have a classical triad of presentation that is elevated body temperature greater than 104 degrees Fahrenheit. Some books say 105, some books say 106. And actually, when the person is being transported with cooling measures taken, there can be even much lower temperatures. The person can have a temperature of 103 degrees Fahrenheit when checked in emergency department. So temperature reading is not a strict criteria, but when you are measuring the temperature, use the rectal thermometer. Then we also have hallmark of the heat stroke, that is CNS dysfunction. The person can present with combativeness, delirium, seizures, coma. Then there is also history of exposure to hot weather or vigorous physical exertion. Heat stroke can be two types, classic and exertional. In classic heat stroke, the age is going to be extremes of age, that is very young or elderly, whereas in exertional, young physically fit. Classic heat stroke occurs during annual summer heat waves at rest, whereas exertional occurs during exercise. In classic heat stroke, the skin is going to be hot and dry, that is due to absence of sweating. Whereas in exertional heat stroke, the person is going to sweat a lot. Classic heat stroke ABG shows respiratory alkalosis, whereas in exertional heat stroke, the person will be having metabolic acidosis due to lactic acidosis. Other differences we can see is in classical heat stroke, there can be pre-existing illness. There can also be history of drug use that could impair thermoregulation, like anticholinergics or antihistaminics. Whereas in exertional heat stroke, there is increased risk of hypoglycemia, rhabdomyolysis, disseminated intravascular coagulation. Coming to phases of heat stroke, we are going to have acute phase. In acute phase, there is going to be CNS dysfunction. Early stages of CNS dysfunction is going to be cerebellar involvement. There will be ataxia, incoordination, dysarthria. Whereas in advanced stages, whatever I have mentioned earlier, combativeness, delirium, coma, seizures can be there. Other than this, we can have diarrhea, vomiting. The person can also have high output cardiac failure. Then coming to hematological and enzymatic phase. In this, we are going to see leukocytosis and thrombocytopenia when we do complete blood picture. There can also be elevated prothrombin time, activated partial thromboplastin time, and D-dimer when we do coagulation studies. We also can have elevated enzymes, most sensitive being creatinine phosphokinase. And the second most is LDH, and there will be even myoglobinuria. These three are seen in the skeletal muscle injury. We can also have AST and ALT elevation that indicates liver impairment. This is the most consistent feature that is seen in heat stroke. Late phase involves multi-organ dysfunction syndrome. There will be acute renal failure, which will be manifesting as anuria or oliguria. In suspected heat stroke, we are always going to do one thing, that is cooling first, then transport. Bring the person to the shade, offer him with water and electrolytes, cool water, in case he's mentally alert and active. You can also use some other cooling techniques like immersion, spraying water on the person, providing with ice packs under the groin as well as axilla. That also can be done. Rapid cooling is most important because it protects from CNS damage. We are going to do ice water immersion and also massage the extremities so that there will be cutaneous vasodilation and increased heat dissipation. Safe in young individuals who are healthy. Cooling can be done till core temperature falls to 1 or 2 degrees Fahrenheit. The other cooling strategy is evaporative cooling. This is better tolerated by elderly patients. Cool water spraying and fanning. Fanning involves blowing hot air. Why this is done is because we want to keep the skin temperature at optimum range to prevent shivering, which is counterproductive during this cooling process. Ice packs are placed in the groin region as well as axilla. Supplemental oxygen is given. Fluid resuscitation is done. Cold fluids are given at the rate of 300 ml per hour initially and then titrated according to urine output. We want to maintain at least 0.5 ml per kg per hour of urine output. Be careful of pulmonary edema. There is increased risk. Seizure control is very important because seizure itself increases the body temperature. So we use benzodiazepines like lorazepam or diazepam, and in case it's not controlled within 10 minutes of giving the first dose, you can also give second dose. Then we also have to control shivering. So for shivering control, we can use again diazepam or you can use even meperidine. In myoglobinuria and renal failure, we are going to give furosemide. We are already giving hydration, so we are causing even diuresis. And in case CPK levels are more than 1 lakh international units, go with alkalinization of urine, and hemodialysis also can be done. In case of coagulopathy, go with fresh frozen plasma and platelets. Among investigations, we have complete blood picture, RFT, LFT, coagulation profile, CUE, electrolytes, GRBS, ABG, and many more like creatine phosphokinase and other enzymes, which we already discussed about these investigations in our previous slide. Prevention involves heat acclimatization. Heat acclimatization is a process where we are going to train the person's body to adapt to higher heat, and this is achieved in few days by exposing the person to brief period of heat stress. Wear lightweight clothes and absorbent clothes. Person should be reducing the physical activity with respect to extent and duration. Limit the exposure to the heat, like for example, let us say reschedule the events to cooler times of the day. Increase hydration, cold showers. Thank you very much. All the best.